and then we'll start to talk. So we're very excited that Dr. Uflacker is here tonight, to speak to us about interventional radiology. So Dr. Uflacker is a faculty member here since, I believe, last year, but he graduated from MUSC in 2009. He did his residency and fellowship at UVA, and he has research interests that are focused on embolic therapy, and he's actively investigating the application of particle embolization in osteoarthritis. And I think he does a lot of other cool clinical stuff that he's going to tell us about today. So if you have any questions for Dr. Uflacker, if you can also just put it in the chat, and I think he'll be able to see it, and then you can take it away. Thank you so much for joining us.
Okay, you're welcome. Thanks for the introduction. So this talk is kind of intended as a pretty general intro to interventional radiology. It was put together by one of my partners, Thor Johnson, and I made some changes to it as well. And we like to do this talk for students interested in IR. We'll talk a little bit about the history of the specialty, kind of things we do, and what's to come ahead. So the history of IR is it started out as a subspecialty of radiology, and that's no longer true right now. IR is a specialty in and of itself, recognized by the ABR as its own medical specialty, which means we have our own residency. And the remaining things found in the statement are still true. So we're a specialty that utilizes minimally invasive image-guided procedures to diagnose, treat diseases in virtually every organ system in the body. The concept behind it is that we can use these imaging techniques to treat and diagnose conditions being as the least invasive as possible, minimizing the risk to patients and improving outcomes. So we have a very close relationship with other subspecialties like vascular medicine, specialties like urology, oncology, neurology, GI medicine, nephrology, general surgery, and general medicine. So we, and there's multiple other specialties that we are involved with as well. Emily alluded to some work we're doing in orthopedics, which is for arthritis, so you can throw in orthopedics and rheumatology in there. So we are kind of all over the place. Usually the neurology association is dealing usually with neurointerventional radiology, but we do a lot of spine procedures, pain procedures as well. Those things are all related. Palliative care is another huge area that we are involved in, as sometimes we're the only option for improving patient quality of life when they're reaching the end of life. So IR is a fairly young field. It can kind of trace its origins back to 1929, when Werner Frossman did a self-catheterization. He basically placed a catheter / wire from his cubital cephalic vein into his right atrium, and then he went down to the X-ray department and took a picture. And I think he was fired actually for doing this, but up until that point, everybody thought that if you put any kind of instrument inside the right atrium, it will cause a fatal arrhythmia and kill you. And now we know that that's extremely rare and is not really the case. And central lines are extremely common, and this, in fact, looks exactly like a PICC line would look like if we placed one today. So Frossman was a little bit of a maverick with this technique back in 1929. He did fine, and this was one of the first experiments that he that were done in this area that allowed people to build upon. But IR really was born in 1953 when this guy, Seldinger from Sweden, came up with this idea of using the Seldinger technique, which we talk about ad nauseum, and you're going to hear about a billion times throughout throughout your medical education and in the future. Basically, what the Seldinger technique entails is placing a needle inside a vessel, biliary duct, bowel, vein, you name it, collection, and then through that needle sticking a wire into it. And over that wire, after you pull the needle out, you place some other instrument, usually a catheter, over that wire. Up until this point, the way that people access vessels was by doing an open cut down. So you can imagine that this technique, this invention, actually was extremely helpful for getting access into veins and arteries. You no longer had to do an open exposure to visualize a vein to do a puncture. So back in the day, surgeons would open up angiography had been invented already prior to World War II. Angiography was actually something that was invented almost at the same time that X-rays were discovered. And but up until this point, surgeons would do angiograms by doing a cut down into a vessel and sticking a needle into it and then taking the pictures. And this technique allowed it to do it much more in a much more less invasive manner. So the father of IR is considered to be Charles Dotter. He's this crazy looking guy. So Dotter was credited for performing the first angioplasty in 1963 in the leg of a patient, Laura Shaw, sorry, HIPAA, who was a 82-year-old diabetic woman with gangrene who did not want an amputation. And the angioplasty at the time, they didn't have angioplasty balloons. So what he did is he took a long tube called a dilator, which is basically pretty much a solid plastic tube that has a lumen in it for the wire. And over the wire, you track this dilator into the vessel, and the vessel just gets the plaque in the vessel gets crushed open by the dilator, which had its limitations because the dilators are not flexible and they're much more difficult to track along places than an angioplasty balloon, which came about a decade and a half after this. But Dotter had this in the late 60s, has this article by Life magazine written about him, and the article was extremely unfortunate because it kind of cast him as this insane genius that was doing all this crazy stuff on people, and this was extremely upsetting to him. He most of the pictures that they had in the article were with his face kind of like this, and they were very unflattering. And I don't think he got a chance to look at the article before it went to print that they did. But anyway, that was kind of the first time that interventional radiology was cast in the public light. Dotter unfortunately passed relatively young when he was only 65. And kind of the therapeutic basis for the specialty is based on this quote that we are essentially plumbers, but we're doing it in blood vessels. We've always been met with resistance from other specialties. This is a sample example of a angiography request that a surgeon wanted to get an angiogram for a patient to plan a bypass. And he explicitly wrote on the request, visualize but not try to fix it. The patient, Dotter, didn't listen to the request and actually went ahead and did an angioplasty of the profunda femoris, and they went hiking Mount Hood 5 years later. But this kind of relationship between IR and other specialties has been from the beginning extremely common, for better or for worse. And this is just kind of an interesting example of how other specialties view us sometimes. The name and definition of interventional radiology didn't come about until 1969, and this was by a guy called Alexander Margulis, who defined IR as a specialty that uses manipulative procedures controlled and followed under fluoroscopy guidance that may be predominantly therapeutic or primarily diagnostic. He also emphasized that to perform these procedures, there's a need for special training, technical skills, clinical knowledge, ability to care for patients before, during, and after procedures, and close cooperation with surgeons, internists, and other specialists. He also emphasized that IRs should have training in surgical technique because there's a lot of overlap in some of the techniques that are used in the specialty. The specialty name in 1969 was followed by foundation of the society in 1973. The subspecialty was officially accredited only in 1991. So basically, there was no accreditation for IR as a subspecialty up until that point. And people just kind of practiced IR, did a fellowship more or less, but the fellowships prior to this point were more or less informal. They were not ACGME accredited and so forth. The first CAQ, which is a certificate of added qualification, which is a test that you take to demonstrate that you have added expertise in a field that's recognized by the board. That was started in 1994. The exam was first administered in 95. And the specialty status was only about 17 years later. That happened in 2012. These three folks here, this is Ernie Ring and Jean LaBerge. LaBerge was actually one of my board examiners out in Tucson a couple years ago. She's still practicing. They're both at UCSF, and I think this is Cumpy. So now we have the IR residency application, and that's been available since 2017. So procedures that we do. Back in 1967, this was more or less the list of procedures that were performed. We don't do this one anymore, unfortunately. In utero fetus infusion. I'm not sure why we started doing that, but that's fortunately out of the picture. The list of procedures now is, this is a partial list, but this is more or less a list of all the things that we do nowadays. We have twice as much codes as any other specialty has, just because of the variety of conditions that we treat and variety of procedures that we perform. So uniting features of interventional radiology is that it's minimally invasive. You use a small or no incision at all to achieve what you set out to achieve. You use local anesthesia or conscious sedation, although obviously a lot of things we do require general anesthesia, but most of the things we do require only local or conscious sedation. It can be done in an outpatient setting, meaning the patient can have the procedure done and be sent home the same day after they do a brief recovery. And the key thing is that it's image guided. So virtually everything we do is image guided in some way. And that can be done through CT, ultrasound, fluoroscopy, and occasionally even MRI, although that's much less common. So the 5 different types of procedures that we perform: drainages, angiography and venography, biopsies, and ablations. So one of the problems with the classification here is that we're not including things like angioplasty, we're not including things like embolization, But basically, these basic classifications, you can actually start getting subdivided into other things. If you do, for example, the angiography classification, you will go into embolization. Embolization will also be found in venography. Sometimes they're mixed, sometimes we use ablation with embolization, and so forth. So this is an example of tools of the trade that are basic tools that we need to be familiar with. This is a J-shaped guide wire that comes in the standard kit. This is a sheath. A sheath is basically a long tube that allows us to place other tubes through it. It's really an important basis of anything that we do whenever we get access into something. The sheaths usually have a valve, and this valve is meant to keep blood or bile or urine or whatever else that you're doing the procedure in from coming out, but it also allows you to flush saline, contrast, or something else into it. Then through the valve, we place catheters, wires, and a number of other devices. Kind of the workhorse of our specialty is the guide wire. So guide wire is a extremely important instrument because it is basically how we maintain and establish access into whatever it is that we're working on. So the basically the guide wire consists of a long metal or other material, a long string that has different types of coating on it. Usually there's a welded tip at the front with a this coating we call the mandrel, and this the wires come in two basic flavors. They either are hydrophilic or not hydrophilic coated, and there is a huge variety of wire types and depending on their utility and so forth. This invention of the hydrophilic wire was extremely important because up to that point, some catheterizations that were attempted were basically impossible due to a variety of reasons, being plaque, tortuosity, or the patient's anatomy, and so forth. The glide wire, when it came out years ago, it was developed by a company called Terumo. That really expanded the ability to technically select things and allowed us to be much more successful. So catheters, this is the second workhorse of IR, is diagnostic and therapeutic catheters. There's a variety of different shapes. Some of these shapes I used in interventional cardiology. Some of these shapes I used for different, specifically for selecting different vessels. Like for example, this is a vertebral artery catheter. Although these shapes are extremely broad, we really can perform most interventions with a few of the basic shapes that we find here. So the hockey stick, very similar to a vert shape. That's one of the basic shapes. The cobra shape, these guys down at the bottom, that's another basic shape that we use very often. These are called reverse curve catheters here. This is a Simmons. They come in different sizes, and they're very useful for selecting visceral arteries like the SMA, the renal arteries, and so forth. Some catheters are diagnostic only, like the pigtail catheter. These are meant for delivery of large volumes of contrast and other materials to perform angiograms, for example. And back in the day, these catheters shapes they were limited, and the interventionalists usually used a wire to shape the catheter that they wanted it, and then they put the catheter on a steam jet coming from like a tea kettle, and the heat would allow the catheter to conform to the shape of the wire that they chose, and they would pull the wire out, and then you would have the shape that you desired to have it. And that was kind of an art in and of itself to shape a catheter, and that's not really done anymore. I think I've done it once when I was in practice, still in Virginia, when I was trying to get into a gonadal vein in a young woman. I shaped my own catheter one time, but that's a story for grandkids now. Not really done anymore. The other category, ablation, this is basically anytime that we deliver energy or some kind of sclerosant or freezing temperatures to an area that we want to destroy. Ablation is essentially the destruction of tissue. This is an example of a metastatic neuroendocrine tumor in the liver. The concept here is that we're going to place these probes into the tumor, and we're going to deliver energy, which can be microwave or RF energy, to heat the tissue above 50 degrees, which is temperature that we need to achieve to kill cells, and treat this lesion. And techniques for ablation vary a lot. This one is an example of an ablation done with hydrodissection. Hydrodissection is when we infuse saline, or we infuse, actually not saline, we infuse D5 typically into the areas surrounding it to protect areas from getting the delivery of the heat that we're targeting towards the tumor. So in this example, it's a very superficial lesion. We're trying to protect the diaphragm. So we are separating the liver here from the diaphragm by injecting some saline into the area to separate the two. Sorry, not saline, but either sterile water or D5. The reason why we don't use saline, especially in RF, is because it can conduct electricity. So you can, the concept of ablation is that you can burn some relatively large areas in solid organs like the liver or the kidney while trying to achieve a margin that will basically allow the patient to recover without recurrence of the tumor. Usually that margin is about 0.5 to 10 millimeters on all sides of the tumor. And there are a lot of things working against you when you're trying to get good margins. So one of the things that works against you is the fact that we have blood vessels in these solid organs, and those blood vessels act like heat sinks, which is very similar to a radiator. And sometimes when you're next to a very large blood vessel, one margin may not get appropriately heated to the temperature that you need. And you may have to do some other combination of therapy to achieve a complete treatment. So talk about angiography. Angiography was kind of the initial, one of the initial purposes of interventional radiology was to take pictures of blood vessels. And angiography immediately translates into angioplasty. So kind of subtle changes here, but if you noticed, we had a stenosis in this artery, put a balloon in it, and open up the vessel. So that's now a much better lumen for blood to flow through. This is an example of a iliac angiography. We have an occlusion of the left iliac artery here, crossed the occlusion with a catheter and placed a wire over it, and then did kissing balloons to open up the blood vessel. It's another example, same case, where there was a blockage in the vessel a little bit lower, and that vessel was opened up with stents. Here's an example of the use of embolization during angiography. This is a great case of a patient that had a nephrostomy tube. This is a kidney. This kidney is lighting up over here. The patient had a nephrostomy tube due to some kind of blockage in the urinary system that was causing the kidney function to be impaired. And when the tube came out, that tube was going through a little blood vessel, and the tube was pulled, and now there is blood pouring out into the tract where the tube was. This is where the tube was going through from the skin into the collecting system, which is not imaged here. This is just the cortex and medulla. You can tell there's really good differentiation of the medulla over here and the cortex. You can tell how much more enhancement there is in the cortex over here than there is in the medulla. And this is where the is one of these little branch arteries is where it's bleeding from. And we can go in there with very tiny, even smaller than the other catheters I mentioned to you guys. These are micro catheters. These are catheters about the size of angel hair pasta. We can put into these tiny little branches and get a very localized treatment to treat this bleed. Placed looks like a single coil here that was able to stop the bleeding. And yeah, we do knock out a little bit of the blood flow to the kidneys. So this cortex is going to be unfortunately sacrificed for the treatment of this bleed, but it's about as good as it gets in terms of stopping hemorrhage in the kidney. There's a wedge-shaped area that's not getting as much contrast as before. That was the area that was bleeding, but the important thing here is that the patient stopped having this bleed coming out into the tract where the tube was. Venography is another very important application of interventional radiology skills. This one is we'll talk about venography particularly in the setting of the liver and portal hypertension. So typically the normal portal pressure is less than 5 millimeters of mercury. What happens in cirrhosis, as you guys are probably learning now in the curriculum, is that the normal sinusoidal structure and architecture of the liver gets interrupted and pressure inside the portal vein starts to rise. And as that pressure rises, blood's going to attempt to find other ways to get back to the heart. And because it's not going to go through the liver easily, now it's going to try to find other ways. And one of the most common is going through this vein here called the left gastric vein, which communicates with these little esophageal veins, which are all over the esophagus and most prominently at the gastroesophageal junction. And these eventually will communicate with the azygos vein, which goes back to the SVC or the IVC. And these veins are not intended to handle a large amount of blood, so they dilate. And whenever a blood vessel dilates, it becomes weaker, exponentially weaker as it gets bigger. And this puts the patient at risk for bleeding. So one of the most catastrophic complications of cirrhosis is a variceal bleed. Patients that have a pressure greater than 10 millimeters of mercury in the portal vein are likely to get ascites, which can be extremely uncomfortable and debilitating. And only a couple millimeters of mercury more, patients are going to be at risk for suffering from bleeding varices. So, and if that pressure keeps going up, and it can go quite high, pressure greater than 20 millimeters of mercury is a very high risk for death, up to 64%. So management of complications related to portal hypertension is something that we perform routinely that can make a huge impact on people's lives. Like, for example, this gentleman over here is a cirrhotic, has a huge amount of ascites in his belly. You can see he's got this clinical exam findings, which you guys should be familiar with. This is called caput medusae. This is basically blood vessels or veins rather in the interior abdominal wall that are part of the collateral network that are trying to get blood out of the portal system into the systemic system. So this gentleman was a candidate for TIPS, and he underwent TIPS successfully. for ascites, but we can also perform TIPS for bleeding varices, portal vein thrombosis prior to transplant, hepatic hydrothorax, which occurs in patients that also have ascites, but localized to the chest, usually because there are little communications in between the abdomen and the thorax via the diaphragm. And in some patients, they get the fluid buildup predominantly within the chest, causing shortness of breath and dyspnea and so forth. Another indication for TIPS is to treat hepatorenal syndrome. So hepatorenal syndrome is a pretty complex condition, but I'm oversimplifying a little bit. But in patients with cirrhosis, they typically have really low blood pressures, which means that their kidneys are hypoperfused. And the reason they have the low blood pressure is because they have they can't produce albumin as much, which means that the oncotic pressure inside the intravascular space is going to be lower. So fluid is likely to build up in the extravascular space. Also, the increased portal pressure is going to force fluid out into the extravascular space. So that combination of issues causes kidneys to be chronically hypoperfused, and TIPS can restore that and restore renal function in a lot of cases. Basically, the concept of TIPS is that we go in from the neck into the jugular vein. We're going through the right atrium of the heart here, put a big crochet-sized needle from the hepatic vein into the portal vein, put a wire through it, put a balloon through the track that we created, and then we drop a stent in, creating a direct connection through the liver parenchyma from the portal vein to the hepatic vein. Here's an example. Here's a sheath in the right atrium in the hepatic vein with a diagnostic pigtail catheter. And the splenic vein over here, there's an injection of contrast, showing contrast going into the inferior mesenteric vein over here. Superior mesenteric vein is here. You don't see it, but there's flow going into the portal vein here. Sorry. The catheter is placed through this parenchymal tract that was artificially created with the needle pass into the portal vein over here. Okay, these are some gallstones here just for fun. This other thing is a another sheath that contains another device called a ICE probe. The ICE probe is a intracardiac echo device that allows you to have a real-time visualization of the targets that you're after, which is usually the right portal vein. Although this one looks like they enter kind of at the branch point. But the ICE allows you to kind of target it directly, and it's a newer technique that we've been adopting, and it helps save passes through the liver. Because what you're trying to do in a TIPS is, one of the main things you're trying to accomplish is create this shunt safely. And if I didn't go through it, TIPS stands for transjugular intrahepatic port systemic shunt. And this shunt requires placement through hepatic parenchyma, which contains things like the hepatic artery. And the more times you poke through the hepatic parenchyma, the more likely you are to cause some kind of complication like a bleed. And if we can minimize the number of those passes that you make, your patient is less likely to have a complication. So the ICE probe actually really helps us visualize things and helps us orient ourselves a little bit better than without directly visualizing it. So once we have the access in and we confirm that we're in the right spot, we place this balloon. The balloon will open up the track to kind of give us space to put the sheath down so we can place the a stent graft through it. This is a Viator stent graft. It's a combination of a bare metal stent over here up to this ring and covered portion. In the early days of TIPS, most of these stents were not covered, and they were liable to get thrombosed because there would be crossing of bile ducts and so forth. And then they developed this covered stent graft that was much better patency rates. And they kept this portion of the 2 centimeters of the stent here bare metal so that blood flow could still go into other veins. uh, in the area that you entered through. So a really good device. It really helped improve the patency rates of these procedures. Drainages is another very common thing. Basics of biliary drainage, for example, using the Seldinger technique. In this case, replacing the blood with bile over here. We are getting the needle inside the bile duct, putting a wire in, putting a catheter in, exactly the same way that we would do any other access. The difference is that in the biliary tree, you have these very small channels called the biliary ducts, and sometimes they can be big, but sometimes they can be really small. And it can be a very tedious and difficult procedure to do sometimes. You're trying to hit a tiny little tube inside a large solid organ. In this case, for example, these are actually relatively large biliary ducts. They are dilated. We got access into one of these tertiary biliary ducts, and there's a downstream obstruction here somewhere that we are going to try to cross with the catheter. So the principle here is we got access into the biliary tree. Looks like the blockage here was at the head of the pancreas near the ampulla. Crossed it with a wire, and we're able to place a catheter into it. And what we achieved here is communication of the biliary tree to the small bowel, which was the intended goal here. That was interrupted. So this is an example of how to perform one. You find the mid-axillary line over here. Place the needle inside the skin and into the liver, preferably over a rib, not under a rib. And then do a pullback until we find pullback with contrast until we find the biliary ducts. Once we find the duct that you enter may be suitable, or it may not be. It may require another access. If you enter a little bit too central, you don't want to place a duct in the common bile duct, drain in the common bile duct, for example. But if you can see other smaller ducts, you may have to go in with another needle to achieve a more suitable access. And then the catheter goes in, bile comes out. And this can be quite difficult, especially in transplant patients who have very, very tiny ducts. They don't usually get very big, even if they get obstructed. This is an example of a patient with acute cholecystitis who's not an operative candidate, and they're having right upper quadrant pain, fevers, and so forth. And we do an ultrasound, did an ultrasound guided puncture of the gallbladder. Here's a picture of our needle in the gallbladder under ultrasound. We can sometimes do this at the bedside. During COVID, we are placing quite a few of these cholecystostomy tubes in patients who are chronically ill. And we usually go to the unit to do these if we have to. We prefer to bring them downstairs to do this, but if we have to, we can go to the unit and do this. This is a patient that had stones blocking the neck of the gallbladder, placed the drain in. This is drainage of urine through through a nephrostomy tube. Patient has a blockage downstream, usually due to stones, commonly due to cancer, causing blockage of the flow of the urine from the kidney to the bladder. That will cause obstructive uropathy and renal impairment and pain. And if it gets infected, it can complicate to some pretty serious issues with sepsis. And we obtain access into one of these calyces over here, place the drain to decompress the system. And then once the patient gets decompressed, we can try to address the distal obstruction with a stent. For example, here's an example of crossing the distal obstruction with a catheter, so we can place a stent through it so we can open up the flow of urine from the kidney to the bladder. Like in this case, this is a double J stent that is allowing contrast to travel from the renal pelvis over here all the way down to the bladder. The advantage of the renal stent is that you don't have a tube sticking out of your side. The disadvantage is that these still need to be replaced, and the replacement has to be done usually with urology's assistant with a cystoscope. Biopsies, we do quite a few biopsies. That's kind of part of our bread and butter. This is an example of a lung biopsy. The lung is, of course, filled with air, and if we poke a needle into it, we are liable to get a pneumothorax. During this biopsy, we noticed that we had a pneumothorax developing. It started expanding, so we evacuated it with a tube and completed the biopsy after we evacuated the pneumothorax. So what's in store for the future of IR? Well, we've completely overhauled our training pathway. We did away with the traditional pathway, which was 4 years of diagnostic residency plus fellowship. Now we have these 3 major pathways, which are the integrated IR residency independent pathways. I don't want to go into a ton of detail about this because there's a lot to say about it, but basically virtually everybody that's going to be a IR is going to get adequate diagnostic radiology training plus 1 or 2 years of IR training. The pathway that is most popular now is the ESIR pathway, where you do 4 years of diagnostic radiology with early specialization in IR, meaning that you have integrated rotations within the within your training, and then you do a 1 year of fellowship afterward, or quote unquote fellowship, which is really considered your 6th year of residency. We still have a lot of stuff to develop. We've been inventing all sorts of devices over the last several years. It's a really exciting field. There are new things that are coming up, like electroporation, for example. This is kind of a neat diagram of electroporation. Electroporation is a type of ablation that does not use heat or cold, like cryoablation. Instead, it uses an electrical current to open up the channels inside cells, and it will spare the extracellular matrix of the tissue that you're in. So it will not destroy vessels. It will not destroy like the collagen matrix, for example. It's only going to kill cells that have the usual channels in them, including tumor cells, which have a lot of them. And it will allow the area to heal better since you're not destroying the architecture of the tissue as readily as you are with RF or microwave or cryo. These are the devices here. These are just ways to prevent non-target embolization. These are micro catheters that have these cups on them, and they allow us to get really targeted injections of chemotherapy or other treatment modalities like radiation beads without injuring other parts of the liver or other organ that you're in. This is a newer device called a Ninja catheter. They have all these exciting marketing names to them. The advantage of this is this catheter is that it's a micro catheter that you can actually change the shape. So sometimes when you're doing selections into really small vessels, you get these vessels will not allow you to select it unless you have a really nice shape to the catheter, and this catheter allows you to do that. Hybrid suites. This is a hybrid CT and fluoro suite. Hopefully we're getting one of these in the next couple of years. It would be really useful for something like a trauma. For example, somebody comes in with a trauma, they get CT. You can diagnose if they have a major bleed, and then you can treat them automatically without having to move departments. Other advances in tumor and oncology, intratumoral injections, for example, we can nowadays have very targeted therapy for tumoral injection with antibody-mediated treatments. Combination of systemic therapy with embolization or ablative therapy. This is an example of somebody with metastatic cancer that underwent a palliative treatment that really improved the disease burden. So we've come a long way. So this from the early 20th century when we were doing fluoroscopy. This is how we calibrated fluoroscopes a long time ago. They basically would shine a bunch of X-rays into your hand, and you would visualize it directly with this gizmo over here. So that would cause two problems. It would cause cancer in your hand and cataracts. So eventually we discovered that X-rays were harmful, and we stopped doing this, and we have all sorts of radiation protections now that are in place. All right, guys, I'll open up the questions. Hopefully it didn't go on too long. Let me open up the chat here. All right, feel free to ask questions. What's the shortest and longest procedure we do? Well, usually the shortest procedures are going to be things like straight venous access cases. One of my partners here is pulling my leg, telling me that TIPS is one of the shortest procedures we do. But it's really not. He's bragging that he did one 30 minutes here. This is Dr. Hannigan. You'll get to meet him. The longest procedures, it depends on what you're doing. So it's all related to the complexity of the problem that's in front of you. So you can have PICC lines that are longer than a TIPS, for example, and that's been the case here, which is why he's saying that. But things like TIPS can last a very long time if you can't get into the portal vein easily, and you have to, or if the portal vein is occluded and you have to use all these adjunctive techniques to get into it, can be very difficult. Venous recanalizations can be very hard to perform. The other short procedures would be straightforward drains. Like if you have a really big collection that's readily accessible, you can usually do that within 10-15 minutes. Biopsies can be quick too. How much interaction do we have with patients? So routinely, we actually are able to do a lot of interaction with patients. We have, when we're doing routine procedures like tube changes or straightforward venous access, the interactions are relatively brief. When we see patients in clinic, however, one of the advantages of IR is that we're not seeing like 30 patients in one morning like a primary care doctor is. We usually only see a handful of patients per day. Like for me, a busy clinic day would be like 8 patients. But we're having kind of long discussions that will involve a really detailed conversation about what we're trying to achieve, and it will involve a lot of details about what could go wrong during a procedure if we're performing one, and it really gives the opportunity to develop a relationship with people. I think most programs take for IR directly. I think if you're not talking about diagnostic radiology, I think they usually take about 2 to 3 residents per year. Some places it's 1. So how many pure diagnostic radiology cases do we do? So you're talking about, if you're talking about invasive diagnostic radiology, like doing straight up angiograms or venograms, we don't do that many anymore. We usually are able to do most of our diagnostic imaging without having to be invasive. So we can usually get the information we need to formulate a plan with a CTA, for example, like a CT angiogram or an MR angiogram. But occasionally we'll still do studies for diagnostic purposes. but that's pretty unusual. Usually the diagnostic study that we'll do will be in conjunction with something else. Like if we're trying to place a line and the patient has a venous occlusions, and we're trying to open up those trying to open up the occlusion, we'll do a diagnostic run to do get information about what we need to do. My favorite thing about VIR is it's actually I think the ability that we have to think outside the box and solve problems on our feet all the time. We're constantly doing that. We have and the difference it can make in people's lives. I think that's probably the two of the things I really enjoy. So that we're not boxed into a single system, and we can really make a difference where nobody else could at some point. So third year one, set up a selective rotation by IR is not offered. Is it possible to set one up, or will I need to wait for fourth year? I don't know the answer to that as far as doing it this year, but we do have IR rotations that you can do as part of your diagnostic rotation during third year. If you're looking for like a 2-week rotation IR, I think you have to wait till fourth year. Yeah. What departments in the hospital do you work with the most? We work with everybody really, but we work a lot with transplant, urology, a lot with oncology. Those are the top 3 I think that we work with. Have you experienced competition from case of referrals of vascular surgery? Oh yeah, so there's a lot of competition all over the place. This is the case all over the country. Unfortunately, we still operate in a for-profit paradigm in our healthcare system, and that's just going to mean that people are going to be competing for cases. So here we're very collegial about what we do. We have a good relationship with vascular surgery, but at the end of the day, yes, we do compete with other specialties. And this can be this competition can be good for patient care, or it can be detrimental to patient care. So if you have good relationships with the surgeons in your institution, that competition will usually become something more or less collaborative, where you can, if you're not able to solve a problem, you get their opinion, for example, or vice versa. But yeah, it is a problem all over the place, and these turf wars are common in a lot of specialties nowadays. There's turf wars between dermatology and plastic surgery. There's turf wars between dermatology and ENT, plastic surgery and ENT, for example. It's a bit of a mess, honestly. But I'm afraid it's going to be the case as long as our system is set up the way it is. Working with so many other specialties, do you feel like those other specialties are trying to train more to do more traditionally IR specific procedures? That can be the case sometimes. It's a very dependent geographically where you go. So if you go to certain areas, the vascular surgeon may be performing TIPS, for example. That's usually a procedure that's been done traditionally by interventional radiologists only. Places like shock trauma in Maryland, and you'll see trauma surgeons performing angiograms. But there are some skills that IRs I think will retain going into the future, like microcatheter skills that very few people will be able to take up without having a dedicated IR fellowship. So how do you feel about work-life balance in IR? So it depends who you ask. I feel like my work-life balance now is pretty good. We are in an academic institution. It depends on what your practice is. We interviewed a guy for our faculty position here a couple weeks ago who was making a ton of money, but he was working 6 days a week, you know, and I just really don't know if he's having great work-life balance for working 6 days a week, but he's making a ton of money. So it varies. If you go into private practice, the expectation should be that you will be doing some diagnostic radiology work, like you're going to be reading CTs, MRIs, and so forth. Usually those private practice jobs are have pretty good vacation packages and so forth. So I think most IRs are pretty happy. Most IRs, I think, are happy compared to a lot of other specialties. I think one of the specialties with the least job satisfaction is actually plastic surgery. You can probably figure out why, but radiologists in general are kind of upper middle of the pack as far as job satisfaction. Anybody else? All right, thank you guys for joining in. If you if you have a question about rotation, feel free to write. My email is uflacker@musc.edu. So I think who asked the question about the rotation? It was Jordan.
Mm-hmm.
Yeah, that was me.
Okay. Yeah, shoot me an email. We'll see if we can set something up. Okay.
Yeah, thank you. I will.
Yeah, no problem. All right, guys. Thank you very much. Hopefully, we'll be able to get together and kind of play with devices and stuff, and do stuff with ultrasound. If not, well, I guess we'll see you when you guys rotate through.
Okay, thank you so much,
Okay.
Dr. Uflacker.
All right. Thanks. Thank you, guys.
Have a good
Have a
evening.
good one. Bye-bye.